When we talk about this interplay between alpha-synuclein and infectious agents, what agents are we really talking about? Are we talking about bacteria, viruses, parasites? Are we talking, for example, about viruses like the SARS-CoV-2, the COVID-19 virus?
In my opinion, regarding synucleinopathies, no type of infectious agent is to be ruled out at this stage of the reflection. We should even complete your list with fungi. So, as you can see, a lot remains to be done.
And speaking about voices, you authored the paper with 3 women patients. And what was that experience like? And did it differ from your usual academic paper writing process?
Absolutely. I think that because they were the voices of women, in some ways, the psychosocial aspects were so front and center, sort of what mattered to them, what their voices were in terms of their daily lives and their struggles.
There is now a growing body of evidence to suggest that levodopa therapy really has mostly a symptomatic effect and may not have any disease-modifying properties to it. So overall, that argues against the compulsory use of levodopa therapy in early PD in patients who don't require it for symptomatic therapy. So given these results, how would you counsel a burgeoning movement disorders neurologist who is, shadowing you in your clinic about when to initiate these treatments in patients? Do you think that we have a firm conclusion at this point, or is the jury still out?
So I think that at this time, I would say that the decision regarding when to initiate dopaminergic treatment should be individualized to the patient. And that decision should result from a process of shared decision making with a conversation centered around not any expectation of disease modification, but the potential for symptomatic benefit and the potential for side effects.
Why do you think the late stage of the disease is important? And do you think we are doing the best we can to help patients in this stage of the disease?
Yes, so patients with Parkinson's disease, when they reach the later stages of the disease, often find it very difficult to come to our clinics and drop off our radar. And for this reason, we often do not really know so much about these patients, and clearly they have great difficulties in participating in clinical studies as well due to their obvious disabilities, and therefore they are very underrepresented in clinical papers, and we so far haven't really had a very good understanding of what their needs are and what the best care should be provided to them.
I wonder about the phenomenology in Parkinson's disease, and especially with punding, the context in which these patients develop the behaviors. Is it just any movement, any specific motor behavior that they tend to recapitulate what they used to do in the past, or is it something new?
Oh, that's quite an interesting point, because punding tends to be idiosyncratic. So previous hobbies or occupations or anything that the patient used to do. So some motor programs from previous routines can be incorporated into the punding routine. And this can be simple or more complex, but it's interesting to notice that punding is meaningless. It can appear to be purposeful, but it's not. So for instance, if you have a musician that has a large collection of CDs, the punding behavior could be sorting CDs the whole night. And in the morning, he would end up with chaos and nothing organized.
There is this new category of possible prodromal MSA, which is one of the new developments of this clinical criteria. So the clinical criteria to enter into this category is basically having REM-sleep behavior disorder proven by polysomnography, a neurogenic orthostatic hypotension, or urinary dysfunction. Again, this is another area of ongoing research, and it is likely to develop in the future. But I would like your comments on this new category and the purpose of it.
So actually, this possible prodromal MSA category is the greatest novelty of the criteria, because we never had this category before in any of the previous criteria.
So you mentioned a little bit about the evolution of use of this technology from spinal cord injury patients. How did the two of you become interested in using this for multiple system atrophy, given that neither of you are neurologists or specifically movement disorders neurologists? Where did this idea come from?
Yeah, even if we are not neurologists, we have a little bit of medical knowledge. And so we knew about this disease, and knowing more about it, we thought about other applications, and we thought about first Parkinson's disease, because there are a lot of people with Parkinson's disease with orthostatic hypotension.
We know a lot about Parkinson's disease, how it manifests, how to treat some of the symptoms, some of the underlying neuropathology, but there is something we do know nothing at all, and that is how it starts. Now, you apply the statistical method to try and understand better the pathogenesis of the disease. Before we start discussing about the results, what is the Armitage and Dole multi-stem model, and where does it come from?
It's an excellent question. And I guess fundamentally what we were trying to understand with this article was whether there is something about the age-specific incidence, so the way that incidence of Parkinson's varies across the lifespan, that will tell us something fundamental about the way the disease develops. And that's something that's actually been looked at in other clinical scenarios, and particularly the cancer literature, dating right back into the 1950s, which is where the Armitage-Dole model that you reference comes from in the first place.
Thank you.
Thank you.
Thank you.
Thank you.
Thank you.
Thank you.
Thank you very much. It has been a pleasure to have you on the MDS podcast.